My talk will be about measuring alignment and different ways to do so. And I've got no declarations of interest. Some background. Alignment is an important criteria in primary knee arthroplasty. We use it preoperatively, especially in determining our distal femoral cuts and determining what prosthesis to use. And post-operatively, it's been associated with longevity. Well-aligned knees tend to last longer. It's been associated with patient function. Patients tend to do better with straighter knees, and also patient satisfaction. So in the outpatients, one of the things the patient's after is a straight knee afterwards. There are lots of ways to measure alignment. The most obvious is just during visual inspection, which tells you roughly whether it's varus or valgus. The next step is X-rays. Short limb X-rays can give you an idea, but they tend to be inaccurate, especially with bowed femurs or tibias. And the current considered gold standard is the long limb X-rays, which is often used in research. CT, especially CT Perth protocol, has a component for alignment as well. MRI is rarely used. Intraoperatively, we can use supine fluoroscopy, but that's again rarely used. And navigation has taken over the role of intraoperative measurement of alignment. So since the days of navigation, there's been quite a few studies looking at alignment and comparing navigation alignment measures with those of long leg standing radiographs. All have found discrepancies in alignment, especially post-operatively. And all have come to the conclusion and made the hypothesis that computer navigation is more accurate and have questioned the use of long leg radiographs in knee arthroplasty. So our question was, can we prove if either technique is more accurate than the other? And if so, which one should we be relying on? So we decided to undertake a project looking at alignment, including the often used long leg radiograph and navigation, and also introducing CTs on patients to try and identify whether we can prove whether one or the other is or isn't more accurate. So a prospective trial with human ethics was undertaken. 40 patients were recruited, the majority being female, as representative of the cohort at St. Vincent's. Most of them had osteoarthritis and all underwent a DePuy PFC computer-navigated knee replacement, majority being cruciate retaining. We performed long leg radiographs 6 weeks preoperatively at a pre-admission clinic. At St. Vincent's, we've designed a perspex stance on which the patient stands on. And this ensures that the malleoli are 10 centimeters apart and the knee is facing forward. And all the radiographers are well aware to make sure that the X-ray beam is as parallel to the knee as possible. Alignment was calculated typically as the difference between the femoral and tibial mechanical axes. And all X-rays were measured 3 times by 3 separate people at 3 different settings in random order. With CT tomography, all patients had a CT Perth protocol 6 weeks post-operatively. Because of funding and ethics, we couldn't perform these pre-operatively as well, so we had to just stick to the post-operative CTs. So to measure alignment, we reformatted all the CTs to make sure the tibial tubercle was facing forward, and the 3 centers, 3 points we were looking for were within the CT, and these were measured again 3 times by 3 different observers. Intraoperative navigation was considered pre and post. So pre was pre any bony dissection, and the post was after the final components were in place. Patella was reduced every time we measured alignment, and the leg was held in extension by the operating surgeon. So Pearson's product moment correlation was used to determine correlation between the 3. So to the results. The intra-observer correlation was excellent amongst the long leg radiographs and CT, so over 0.99 and 0.98 respectively. Maximum difference was quite minimal, 2.6 being the largest, and the mean difference was well below 1 degree. So inter-observer correlation was also excellent. For the pre-long leg radiographs, it was over 0.97, and the post 0.96. The CT also had an excellent intra-observer correlation. Again, we had a few outliers, with one difference being 6.2 degrees, but in the majority, the mean difference was about 1 degree. So intramodality, when long leg radiographs were compared to navigation, the correlation dropped significantly to 0.78. And we had some differences up to 12.8 degrees and averaging about 4 degrees. And considering our understanding of alignment is that it has to be within 3 degrees, a mean difference of 4 degrees between the two can be considered considerable. Post-operatively, again, the correlation was not that good, especially when navigation was involved, with the highest being 0.671 when navigation was involved. Long-length radiographs had reasonably good correlation with the CT, however, being 0.893. So what we've shown is that long-length radiographs and CT have excellent intra-observer correlation. They're reproducible by the one person. They have excellent inter-observer correlation. They're reproducible amongst colleagues. However, whenever navigation is involved, the correlation tends to drop. And this raises a question about the accuracy of the alignment as measured by navigation and about those hypotheses about navigation being adopted as the gold standard. So there are, looking at the previous studies, they've all had some limitations. Their major limitation being that their long-leg radiographs were never quite standardized. We know from previous studies that any fixed flexion deformity, especially combined with rotation, greatly reduces the accuracy of long-leg radiographs. They also thought navigation to be the gold standard, but we know that when we're measuring alignment using navigation, the fascia is generally not closed, the patient is not weight-bearing, and it's prone to registration errors. The computer is only as good as the points we give it, and especially with points like the ankle, these can sometimes be quite off. Our study itself had quite a few limitations. We still have no proof of accuracy. Although CTs and long-leg radiographs correlate well with each other, this doesn't prove that they're the most accurate method. I think the only way to do that is using cadaveric studies, which unfortunately we don't have the funding for. The CTs were only done post-operatively. Again, we were limited by funding and ethics. And intraoperative measures were not remeasured using new registration points every time. And this would be something to look at in the future, but it's hard, especially with the post-operative measures. So in conclusion, the current literature's indication that long-leg radiographs are less accurate than computer navigation, we believe, are unfounded. We think long-leg radiographs are reproducible, especially when standardized, and they correlate well with CT. Hence, if you're performing CT, there's no point doubling up with a long leg and vice versa. Navigation doesn't correlate well with others, but still the only intraoperative tool we have to measure alignment during the operation. Thank you.